Good evening, everyone. We'd like to call to order the Community Mental Health Full Board Meeting. I'd like to begin by reading our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. Next is adopting the agenda. Motion by Flynn, supported by Birdie. Any questions or discussion on the agenda? All in favor signify by saying aye. Aye. Opposed? Next is item number 3, which is hearing of the public. This is an opportunity for the public to speak. You have 5 minutes. Please use the podium right here, or the microphone, and state your name and address. You have 5 minutes to speak. Is there anyone from the public? Sure.
My name is Ed Ferreira. This is my brother Lawrence Ferreira. My address is 55410 Parkview Drive, Shelby Township. In my opinion, community mental health is in violation of my brother's rights by not providing him with the services suited to his condition, and both his dignity and respect is violated because of his needs are not being met. Lawrence was put on Medicaid spend down in May of 2018. By Friday this week, he loses all support through the county for everyday living and safety. He requires support for meal preparation, food shopping, administration of medication, multiple hygiene issues, handling of money, traveling outside of his residence, even making a phone call, a 911 call. His job of 26 years requires a job coach. He needs a structured and reassuring environment to do everyday living tasks, from wiping a kitchen counter to wiping his backside to prevent future infections. Lawrence was born with mental impairment. His father died when he was 5 years old. He left home at 11 and went to Lapeer State Home. In 1979, until his last day this Friday, he has lived in an apartment setting with rotating staff. So why, after 60 years in the Michigan mental health system, is he now being directed by mental health to live in the guardian's home? That is not the guardian's role. The role of CMH is to provide suitable alternatives, and the guardian chooses amongst them using the best interest of Lawrence. I love my brother, but moving him into my home does no good for him. It's a huge, huge mistake. He views me as his parent, and he views my wife as his mother. That is not the least restrictive environment. Do you want to go home at 68 to your parents' home? The least restrictive environment is what he's been in for the last 39 years with rotating staff and a full-time job coach. I'm 8 years older than Larry and in worse health than he is, and I will probably die before him. I'm more than my mid-70s. What scenario are you folks setting up for him and for my wife? I have a wife who's medically disabled. At our age, neither my wife or myself are able to provide the services of a structured routine and, frankly, the constant prompting that he requires, as stated in both his PCP and all of his psychological evaluations, which incidentally, community mental health never looked at while terminating his benefits. I have found 2 ways to avoid spend down. The first way is don't ever collect SSI and then lose it. Larry had SSI in 1974 when they dumped him out of the state institutions in error. It was an error made by the mental health system and Social Security together. He's now not grandfathered because of an error made in 1974. The second way to avoid it is to get more than 8 hours of countable direct care per day. In the last appeal to the Macomb County Community Health, I was warned that all requests to move current 8 hours to more than 8 hours or 8 hours are being arbitrarily denied. Today, Lawrence does not receive 8 hours of countable time because of prior budget cuts. CMH terminates his support Friday, and he lost his job as a result of that. Those hours need to be replaced with at least an equal number of direct care hours. He's been home with me for more than a week. He stopped his interest in coloring. He stopped his interest in listening to music. He stopped his interest in looking at games and attempting them even. And he talks about his job and his apartment loss to anybody and everybody that he sees. We're required to rewrite the PCP to shift hours and request greater hours. I at least need to do that. But do you know that I can't adjust his PCP because Mork refuses to adjust the PCP? They're not being paid for it until spend down is met. When you call Community Mental Health, they tell you, call Mork. When you call Mork, they tell you, call Community Mental Health. And both of them are at odds. There's no procedure to adjust the hours for his need. My request is that the board refocus their administration of CMH to restore Lawrence's rights, services, respect, and most of all, his dignity, where neither he or I should be begging for the life-sustaining support that he needs. Thank you for listening. I hate prepared statements, but I have to get it all in. And may I leave this with the chairperson? This is some documentation on Larry. Yes, Larry.
Can I say something?
You'll have to ask.
Mr. Ferrara?
Can I say something?
Yes, you may.
I'm Larry Ferreira. I lost my job at Kroger. I don't want to lose my permit. I don't want to lose my friends. Please pray for me. Help me.
Thank you for your
Larry
for
does
your
not
comments.
read. He told me he wanted to say something. His job is the grocery cart. The house is his apartment. The people are his friends. And pray. When I talked to him, and I said, what do you want?
Larry, you're a great communicator. Thank you.
Thank you very much.
And as you,
Sorry, I think you were starting to say something and I cut you off.
well, that's okay. I just wanted, as you probably know, the board can't answer. We don't address, it's not a two-way communication at this point, but somebody from the staff will get in contact with you, and I understand you may have already started that communication.
Okay.
Thank you.
Thank you so much.
You're welcome. Thank you
I
for
left
sharing
some
that.
Documents to relate to a file. There's another 10 inches worth of that at home
All
in
right.
the last 3 months.
Thank you. Is there anyone else that would like to address the public? Please come up to the microphone.
Hi, I'm Maria Carmack, the Assistant Manager at Creative Empowerment Opportunities. I have to state my address, yes?
You can say the address of the company.
Okay, 34820 Harper Avenue in Clinton Township. I'm here with the monthly report for Creative Empowerment Opportunities. Update for the individuals served. In Anchorville, we delivered 300 Meals on Wheels. 2 new individuals started services. They started harvesting veggies from the garden. The fruit trees are now loaded with pears. Classes were attended at the Creative Academy, and the greater community daily percentage is 45%. In Clinton Township, a gentle used vehicle was purchased to start upgrading our fleet. The individuals attended the Armada Fair. We volunteered at the local churches 5 days a week. 2 new individuals started services. They've had success in the fishing classes. The art microbusiness have developed fall wreaths and candle holders and a hand-poured paint vase, as shown here. The candle holders will be $8, vases will be $10, and the wreaths will be $12. There'll be pop-up shops coming up, locations to be announced, but they've got big things coming up for the fall months ahead. And the greater community daily percentage is 51%. For Mount Clemens, they delivered 90 Meals on Wheels. had $150 donated to their fishing program. They started volunteering on a new Meals on Wheels route, and their greater community daily percentage was 35%. For Washington, they delivered 118 Meals on Wheels. 2 new individuals started services. They updated their unisex bathroom. They attended the Armada Fair as well, and their community daily percentage was 56%. Now, as for the company, our level 1 to 3 employees received a 20-cent wage increase in Macomb County effective August 1st. The individuals served monthly in-service topic was recipient rights, and the training provided individuals served with a visual aid to help them understand their rights. I have this attached if anyone would like to see it afterward. It's just a really simple way for the individuals we serve to understand what exactly their rights are, what exactly a violation would be, and how to go about reporting a violation. The individual served, Creative Empowerment Opportunities would like to express our appreciation for the leadership that John Kinch, Executive Director, has provided to Macomb County Community Mental Health. His on-hand experience servicing individuals with intellectual developmental disabilities has greatly benefited the Macomb County citizens. Mr. Kinch should be acknowledged as a positive example of a dedicated public servant. Thank you for your time.
Thank you. Is there anyone else that would like to address this board? Anyone else? Seeing none, we'll move on to item number 4, which is approval of the minutes of the regular meeting of the board held on July 25 of 2018. And you didn't have those prior, but they are. I will give you a little time to review them before we take the vote. Motion by Kraft to approve. Support by Flynn. Any discussion? All in favor signify by saying aye. Aye. Opposed? Motion carries. Next is item number 5, approval of standing committee meeting minutes. 5A of the Program and Budget Committee held on August 8, 2018. Motion by Flynn, support by Doherty. Any questions or discussion? All in favor signify by saying aye. Aye. Opposed? Motion carries. And then item 5B, the minutes of the Personnel Committee meeting that was held on August 17 of 2018. Motion by Doherty. Support by Bush. Any discussion on that? All in favor signify by saying aye. Opposed? Motion carries. Next is item number 6, and it's to approve items A through P. Items A through P. I'm sorry, through Q. I believe we're all approved at the program and budget meeting. We'd all discussed all those and approved them, sent them forward for ratification. Ours from the personnel meeting, I believe. I'll take a motion for anything. Lou? Okay. So, is that to carry forward your votes from committee? Is that to carry forward your votes from committee?
If that's the way you want to do it.
Sure, we'll do that. So, without separating then, we'll just carry forward the votes that were at committee. Okay? So, Commissioner Doherty, will you make a motion to approve?
Motion for items A through S with no votes carried
Okay, I would like to have S separated, so we'll do A through R. A through R? Yeah, we saw that. Personnel meeting, right? We saw that. Okay. So we have a motion to approve items A through R because they've been discussed at prior committee meetings. Any questions or discussion? All in favor signify by saying aye. Opposed? Motion carries with the votes carried forward, same as that committee. Then item number 5 or 6S, Macomb County classification description for Executive Director of Community Mental Health. I was recognizing Mr. O'Connell, Dr. O'Connell. You want to?
Yeah.
Then you can support Lou when he's done.
Motion to support with amendment on page 3, under working conditions and physical demands. The change of the statement, travels 30% of the time within the state of Michigan with several overnight events throughout the year. Change that statement just to say frequent travel with several overnight events throughout the year.
Okay, so we have Birdie. Did everyone hear the change was instead of the travel at 30%, just frequent travel with several overnight? Okay, any discussion or questions on that? Everything else was, all other changes were changes that were suggested at committee. Linda?
Afterwards, I noticed that the original job description was done in 2010,
Yes.
and we have become, the whole thing of the PIHP since then. Did anyone consult the PIHP job description to see if this meets that need?
In anticipation of my resignation and retirement, I had been working with the chief of staff a couple months prior, and so I can pretty much confirm with you that Tracy has gone about the process of looking at other PIHP CEO positions, and those statements are incorporated within, correct? Yep.
I have another question.
Mhm.
So I see some stuff has strike in front of it. And then the, under qualifications or other related area, so that kind of means any kind of degree. It says degrees in social work, psychology, education, public health, and then or other related areas, so that means anything, if we define it as related.
Yes.
Okay.
And the idea was the names of degrees have probably changed
Right.
over the years. And also, if somebody can show that their degree in physical education relates, I'm
Right.
using something way off the reality, but yes, it was just to make it more open for more people to apply.
Thanks.
Anyone else? I don't see any speakers here. Okay, all in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is just to continue the receive and file of the item number 7 there. A, receive and file the mental health first aid presentation that we heard at the program and budget, and also the 2017-18 accomplishments. Motion by Flynn. Support by Doherty. Any? I'm sorry, Schmidt. Support by Schmidt. Any questions? All in favor signify by saying aye.
Aye.
Opposed? All right, and next is Resolution 8, which is to, for the retirement of Catherine Currents. And the document itself will be distributed at a later date. Once again, we have a good writer, so we can know that will be written well. Motion by Birdie, support by Nagovan. Any discussion on that? All in favor signify by saying aye.
Aye.
Opposed, motion carries. Next is the voucher listings. Motion by Birdie to pay the bills. Support by Nagovan. Any questions or comments? All in favor signify by saying aye.
Aye.
Motion carries. Next is the management report.
Thank you, Madam Chairman. Good to see everybody tonight. Regarding our schedules for September, you have your appointment book out. Wednesday, September 5th is Program and Budget Committee meeting here, 6 o'clock.
The 5th,
Isn't that what I just said? September 5th?
it's kind of early.
Yeah.
It's September 5th. The regular full board meeting is Wednesday, September 26th at 6 o'clock here. And as a reminder, the Metro Region Dinner Meeting, which has been postponed a couple times, is going to be held next Thursday, August 30th, at 6 o'clock at Andiamo's Restaurants. That's the one on Hall Road, on the south side of Hall Road. And just briefly for the agenda, I've asked Bob Sheehan to come down, and I've already given the board a white paper. He wants to talk about his CMHA, Community Mental Health Association, the third way mentality strategy that he has going on. Part of that is looking at opportunities for public and private partnerships. I felt it was, in speaking with Bob, that would be a good idea if he presented to the entire metro region about what he's thinking about. And I believe at some point in time he wants to come down and meet with the boards, the local metro region boards and administration too, to further indulge and speak about public-private partnerships as a potential for the future. So Bob will be presenting on that. Given the political climate and what's going on, Alan Bolter is also coming down, and he'll be presenting on the current. Alan will be presenting on the elections, what you can expect perhaps in changes some of the governance leadership legislation in the Senate, what you might be able to expect in the way of lame duck activities that are going to go on. It's always interesting to hear Alan speak. So he's always also on the agenda. I've asked Willie Brooks to speak about how well things are going in Detroit Wayne. Since he's taken over there, we haven't seen Willie in a few months, so hopefully he'll speak about that. Annette Downing is the new CEO for Oakland County Community Mental Health. She's a very upbeat, very pleasant young woman, and I asked Annette to introduce herself, speak about some of her interests, because I think all of the other boards would like to understand who Annette is. And then at the same point in time, I'll just briefly mention my departure as well. We may have room for one more agenda item, and I'm working with Willie and Annette on that right now. Annette, she's pretty progressive, and she has some ideas around anti-stigma and some new naming and coining of anti-stigma efforts. So I think she may speak about that as well, too. So the agenda, I think, is pretty full. If you have another idea or suggestion, let me know. I will be certain to reach out to Jonathan Langsman and let him know what the agenda holds. I hope everybody's there and participates. Not only the board, the staff, the CMH staff always seem to be pretty progressive in being able to support the Metro Region Dinner Meeting. So it's 6 o'clock, doors open, August 30th at Andiamo's. Tomorrow night is an open discussion being held by the AMI, Alliance for Mentally Ill of Michigan. It's with Debbie Dingle. It's at Beaumont Hospital on 12 Mile or 13 Mile in Royal Oak. So I'm going to go and support the AMI of Oakland County in that advocacy effort. I would encourage the board or administration, anybody else who's in the area doesn't have anything else to do and want to continue to support and advocate for mental health services, to meet with Congressman Dingle. That would be cool too. That's tomorrow night at 7 o'clock. The doors open at 7. It actually starts at 7:30, and that's at Beaumont Hospital in Royal Oak. Administration Building Auditorium. And then the last thing I want to report on, and I want to turn the mic over to Jim, because I know the board is interested in a couple other items. The board's already approved the PIHP contract. So when we came here back in, August, July. We already received the PIHP contract. We don't know our rates for 2019 yet, but we signed the contract. That's how it always goes. So the contract's been signed. It's been executed by myself, the county executive, per your direction, and the department. We don't know the revenues yet. The department is also converting to an electronic format. And so yesterday I worked with finance and I accepted the revenues for the general fund contract. That's our other big contract, is the general fund contract. Oddly enough, we don't have the contract yet, but the monies are coming electronically. So I go into this database called eGrams, Michigan eGrams, and I accepted the revenues that we're going to receive for general fund monies in the amount of $8,131,000 and some change. That amount of money, and plus there's another $1 million. We were awarded that other $1 million. So our total allotment in general fund monies for 2019 is going to be $9,131,602. That's really a difference of just $10,000. Last year, we received, I don't want to make this confusing, maybe I already did. Last year, we received $8,141,000. So this year, we're receiving $8,131,000. So it's pretty close. Last year, we received $5 million additional, right? This year, we're receiving just $1 million. So my point in bringing this up tonight, I just want to let you know that I already signed off and accepted the monies. And then I would suspect by next month that the CMHSP contract will come before the board. I haven't seen it yet. We were all required to go online, accept the monies, and I'm just advising you that I've done so. They're moving to electronic format, and I'll take any questions if you have any. And if not hearing that, that's really the extent of my update. I'm going to turn it over to Jim because I know the board is interested in the urgent behavioral health care center, the UBHC, where we're at, where we're going with it. Also, developments related to Henry Ford Hospital Systems, the emergency psychiatric evaluation program. So I'm going to stop there and ramp up, Jim. Thank you.
Okay, thanks, John. I'm going to pass around handout we have. All right, we'll give that a second to get around. As everyone's aware, we've been implementing the UBHC and monitoring the success or lack thereof of the UBHC for several years now. Last board meeting last month, there was some lengthy discussion in terms of the future of the UBHC, and part of the direction that we had received was to look at the finances and the program operation and try to figure out if it's possible to make it affordable. If it's not affordable, we can't make it affordable, we need to look at an exit strategy in a way that we might be able to move the functions of the program into a way that are more affordable and don't create such a drain on our general fund resources. As you may know, and we brought periodically a spreadsheet to the board with graphs in terms of the GF expenditures that the UBHC has cost us by month for about 16 months now for the board to review. And as you might recall, that graph kind of goes up and down, and we experience a very wide range of expenses that end up being attributed to our general fund resources. One of the things that we tried to do along the way was to make adjustments to that program to try to figure out, okay, what's the right combination of services? What's the right mix? What's the effort that will finally provide us with a effective, sustainable, cost-effective, and fiscally sound program? Unfortunately, we have not been able to come up with the mix at that building, at that location, that makes sense, that provides us with an opportunity to not have that drain on our general fund dollars. So over the last 6 weeks or so, we've undertaken a planning process to start looking at an exit strategy. How do we move away from the UBHC in the location it's currently in and make the essential services still available to the community, to make the services that we've made adjustments to along the way and have found to be effective, how do we carry those on and make them available to the community in the most cost-efficient way possible? What we've done is to really look at what's been effective, what's not been effective, what's been clinically effective and fiscally effective. And then also the requirements, the required programs that need to happen as part of, that we're going on at the UBHC. One of those being intake and assessment. That's something we have to do with everybody that seeks access to our services. And so it's something that, whether we're doing that out of the UBHC or doing it out of another location, that still needs to be done. And so it's a function that the PIHP and CMHSP are responsible to provide, and that's really the assessment that provides entry into the MCCMH services. It determines the clinical need and what level of care that consumer will end up with within our system. So we need to maintain that. We were also interested in, and based on some of the discussion we had at the previous board meeting, interested in distributing that function on a more community-wide basis. So one of the things that we determined we wanted to do was to take the intake process, and really you've heard the terminology open access, and really that allows for consumers to come to the clinics and receive this service on an unscheduled basis. They can walk in, they can be referred by our access center, but they don't necessarily need a scheduled appointment time to come for the intake and assessment. So we wanted to distribute that throughout the county. So we have plans to have that available through our First North building, our First Southeast building at 10 Mile and Harper, and also at the CCC, the First Southwest location at 15 Mile and Van Dyke. So we're trying to distribute that function throughout the county so that there's greater access for consumers throughout the county, and hopefully we can drive the volume, being a more distributed program, to those sites in order to make that a little bit more cost effective. We met initially with the staff has been meeting for a number of weeks to come up with a plan that made some sense in order to maintain the essential functions and the desired functions and try to do it in a more cost-effective way. We did meet with the staff at the UBHC on July 25th and provided them with a broad overview of potential changes. We haven't gone into a whole lot of detail because we're still doing a whole lot of planning and deciding on what the best direction to go will be with some of the details. The union was represented at that meeting, so they have heard that initial overview of what the plan is. To get down to some of the nuts and bolts, there are 13 staff there that will be reassigned to current MCCMH programs. Some at the same location. They'll be reassigned to the ACT program, Crisis Stabilization Program, that are still operating out of the UBHC, the Garfield building. Others will be reassigned to the First North, First Southwest, and First Southeast buildings in order to provide that open access function. So we're taking that function from the centralized location and distributing out throughout the community so consumers can have better access to those services. The open access hours will be, at least at this point in time in planning, 10 to 3, Monday through Friday, 5 days a week. And then we'll also be doing scheduled intakes from our access center. So when somebody calls, we can block out a time for that person to come in same day or next day, which is obviously a much more rapid access to services, which is part of the goal here. They can come same day or next day in order to receive that initial intake and assessment for services. So and as part of that intake process, the assessment is done, a level of care is determined based on that assessment, and the assessment really looks at a variety of demographics that are required by contract that we collect, as well as clinical history, functional strengths and deficits, as well as clinical service and support needs. From there, the assessing department or site sends a recommendation back to the access center, who determines the level of care need and makes a referral to an appropriate service provider. So somebody could go to First North, the assessment's done, determine that they need ACT services. Access center would confirm that assessment and that level of care and make a referral to ACT services for ongoing provision of services. We also, as we were making modifications to try to make the original program more effective, developed a day of discharge program, and you may have heard a little bit about this. I think we talked about it at the last meeting a little bit, where we are working with Henry Ford Hospital to, on the same day that a consumer is discharged from the hospital, have them come over to our intake site, receive a clinical intake at that point in time, and get it set up for services. Often, because of the nature of our network and the demand on psychiatric services, there often isn't a psychiatric appointment within our network on a more immediate basis within 2 weeks, 4 weeks. And so we'll carry that consumer sometimes. We kind of call them bridge services or interim services, where somebody's been discharged from the hospital, but we know they're going to run out of medications at some point. And rather than have them cycle back in through the hospital, we'll provide a med review on a kind of an interim basis for the consumer so that they don't cycle back into the hospital until we can connect them with a provider that can offer a med review on a timely basis. So it's something that we're trying to do in order to keep people from recycling back into the hospital. We've had a recidivism rate that hovers right around the threshold that the department expects, and sometimes exceeds the 15% threshold. And so we're looking for ways to make an impact on that. And we did, thankfully, for our last reporting period, I believe our recidivism rate was about 12 or 13%. So we were able to make a little bit of an impact in terms of the recidivism and people cycling back into the hospital, primarily because they're running out of medications. So that program will be relocated to First North, which is actually a little bit closer to Henry Ford. So in terms of the transportation issue, be a little bit less of a demand in terms of getting consumers from the hospital to the service site. And we're also looking to expand it to our southeast site and to look for an additional partner to do this on that side of town, the more southern, southeastern part of town. So working with a hospital in order to provide the same type of program where we'll transport over to our site, do the intake right away, try to connect them with services as soon as possible to not lose that engagement once they're coming out of the hospital. So we haven't determined a partner at this point in time, but we're reaching out to some providers to see who might be interested in doing that. The services that are provided at the day of discharge program are transport for the hospital to the MCCMH intake or open access site. That would be First North. The intake assessment for potential need for MCCMH aftercare services. Case management as medically necessary, medication review as medically necessary, and then as those services are available at other providers, referral over to the other provider. part of the goal here is to just not have anybody fall through the cracks, and make sure that continuity of care continues between the hospital discharge and the first appointment of the contracted provider. The service eligibility for the program is going to be restricted to Medicaid. This is where we ran into a little bit of a problem with the UBHC. I should say a lot of a problem with the UBHC is that we were taking all comers. The consumers that were coming in without Medicaid, those services were being charged to GF, and that created part of the drain on those services. So we're restricting this to strictly Medicaid consumers. Access will be either via Access Center referral or walk-in from the community for our open access program at these sites. As far as the facility goes, our Garfield building will remain open. We're currently housing assertive community treatment, crisis stabilization, crisis center. Office of Recipient Rights is doing training there. And we're looking for a unit that we can move over there to fill that space that the UBHC staff will be moving out of. We have a couple of potential options. One building closure where we have a lease that's coming due this fall that we may be able to move that unit over, close the building that they're currently in, and use up the space that's been vacated at the Garfield building. Marketing will be a big part of this. We need to make sure that we have an opportunity to get the word out to the community and stakeholders. We're working on some things that we've been successful with in the past in terms of prescription pad size, referral cards to provide to physicians' offices and other locations. They proved to be very popular when we were doing walk-in services a few years back. And we're looking at different opportunities to get the word out to the community and folks that need to know about the availability of the open access program and what time those services are available and how to go about accessing them. We hope to have the transition complete and have this all implemented by October 1. We still have some details to be worked out. We're currently, in fact, I had this afternoon a consultation with AFIA, the group that is doing our part of our data analysis, as well as providing subject matter expertise, and we're talking with them about open access and pre-screening sites to try to make sure that we're doing this in a way that makes sense and is sustainable. So that's it for the UBHC report. I can do the EPE piece of it, or do we have any questions on UBHC while we're...
What were those last initials you just said you could do?
EPE, Emergency Psych Evaluation.
Yeah,
It's the second part of your handout.
Let's take questions regarding the UBHC concept anyway. I don't see anyone on the list, but did you? Okay, Selena.
Jim, I have a couple questions for you. Will you be expanding that hospital discharge to the other psychiatric hospitals?
The day of discharge program?
Yeah.
Yes, we're looking for another partner right now to do that out of our southeast site.
Okay.
So yes, we do want to expand that.
So for the hospitals that aren't partnering with you at this time, can those patients that are being discharged be sent over as a walk-in?
Well, I tell you what, let me get back with you on that. I want to make sure that we have enough capacity to handle that, because I think we're trying to gear it up as far as staffing based on what we know, what our history has been with Henry Ford in terms of that discharge. And as we work with other hospitals to implement this, we'll be looking at, okay, how many discharges are we going to have on a regular basis to make sure that we have sufficient staffing in order to manage the demand that comes in. So let me get back with you in terms of how ready we are to commit to that right now.
Okay.
Okay.
Have you guys looked at how to address one of the biggest obstacles that the inpatient providers have upon that discharge is they're required an aftercare appointment. It cannot be a walk-in clinic. It has to be an actual appointment with a date and time. One of the struggles is getting that long-acting injection. So if they're on a 2-week or 30-day, often we cannot get an appointment for those type of things.
Yep.
Is there any thought at some point opening something up like that so that these consumers aren't falling where the appointment comes, it goes, you can't get in anything, and the next thing we know, they're back in the emergency room because what we started on is that long acting and they're not getting it in a timely manner?
That is part of this program. That's the medication review can be to prescribe or to continue a prescription of a long-acting injection. So yeah, that's part of that bridge service, that before they're connected to the provider that will provide the ongoing services, we have the capacity to provide a med review as part of that program for 30, 60 days, depending on how long it takes to connect with the provider with a psychiatric appointment. We're recognizing the same thing, and that's why we've kind of put this into place, is that the lead time, the out time for a psychiatric appointment right now is, 2, 3, 4 months out.
Right.
And we know that we can't have somebody coming out of the hospital and not having medications for that period of time. They're just going to cycle back in.
Okay, so the med review will also be the administration of it?
Typically, that's the prescription of it, but we're talking about whether we'll have nursing staff. Most of these clinics will have nursing staff available that can provide a injection to consumers that are connected to our services. Yep.
Thank you.
Anyone else? Linda?
Jim, I have 2 questions and then just a comment. When UBHC first started, one of the first things that you reported were incredible savings in terms of hospitalizations, and it was just like really something to see. Then that kind of never, kept getting worse and worse in terms of our hospitalization costs. Will this reverse some of that upward trend in the hospitalization costs, like what UBHC provided at first?
Well, as you'll recall, UBHC initially was a diversion program. Part of the intent there was that we would have people come in, we provide crisis intervention with the expectation that we'd be able to divert them. We certainly had some lofty goals in terms of what we could realize in terms of savings. The current implementation, we do expect will have some impact on inpatient admission, simply because people are going to be able to access appropriate services much quicker. Previously, when someone was calling for a appointment for services, it'd be somewhere in the week to 2 week range for them to get in for an intake. If somebody's experiencing severe mental health symptoms, that's a long time. And for somebody to wait 10 days before they were able to get that intake, a lot of times they're going to the hospital before they can hit our door. Now we're offering that service same day or next day, so it should have an impact there. Also, the day of discharge program, where we're able to provide those bridge and interim services, that the sole intent of that is that consumer have a continuum of care and not fall through the cracks and result in a recycling back into the hospital, which obviously would be an additional inpatient admission. So yeah, we're hopeful that as we do this, that those ability to access those services on a timely basis will lessen the incidence of inpatient hospitalization. As part of our data project too, we're watching very, very closely in terms of hospital admissions, diversion rate, where consumers are going into the hospital, how long they're staying. So we're looking at all these things and making sense of that data and trying to use that data to better design these programs.
Now, I don't quite totally understand what the day of discharge program is going to look like. So I have a question. So I'm sick and I leave the hospital and I have to go to a building on Garfield. That doesn't. My question, I guess, is why can't the services be done at the hospital and then make the referrals from there? So I don't have to go to a strange building on Garfield with a new staff and I just get out of, still have my bracelet on, my hospital bracelet on.
Right.
I defer to Selena on some of this, but.
Well, from our perspective, we're talking about a service that's gonna take a couple of hours. We would have to be able to carve out space at the hospital location. One of the things we're doing, because it's on a limited basis right now, with Henry Ford, we are actually transporting the consumer from Henry Ford, where they notify us that, we have 5 discharges today. We go over there and pick them up and take them to our clinic. It will be moving from Garfield to First North, which is, I think, the 1.5 2 miles.
Sure, that's close.
So very close proximity. And as we look for, the partner on the southern or east side, we'll also be doing the same thing where we will arrange for transportation from the hospital to our clinic. And, part of that is that, even if you say, meet me over there, many
Sure.
of them don't make it.
Sure, sure. And then my last point is just to applaud your determination to really look at marketing to the stakeholders. I think was the missing piece, one of the missing pieces at UBHC, that the people who would make referrals to you and use it and drop people off, and the police and all around the county, that just really was a weak spot in UBHC. So I support
Right,
that.
I agree.
Nick?
Two questions, Jim. One is, one of the things we were doing at the UBHC was being able to maintain the 24-hour crisis hotline. How does this affect that, number one? And then number two, by limiting it to Medicaid, does this take us completely out of the jail diversion program, which is generally a general fund program? And if so, how do we replace that or fix that?
I'll try to answer the second one first. Jail diversion, I believe, don't we have some county dollars that are supporting jail diversion? So those county dollars will support that part of the program. We also, in the last grant that we received.
But I'm concerned about getting them. I'm concerned about when the police officer picks somebody up, where do they then take them to be evaluated if they're deciding they want a petition rather than seek a warrant?
At that point, they should go to the hospital ER.
They'll have to just go to the hospital
Right,
ER.
yep.
We can't hear your conversation.
I'm sorry.
Sorry.
These mics aren't that good. So they'll any hospital ER, because before it used to be a hospital ER.
No, it can be any hospital ER. Any hospital would be equipped to do an evaluation and then contact the Access Center in terms of the authorization for inpatient admission, whether that's appropriate or we would look at a diversion.
Okay. All right, thank you. And
And the first question, no, it does not affect that. Crisis Center will still be housed at the Garfield building on a 24/7 basis.
All right, anyone else have a question? All right, I have a question, and part of it was answered, I believe, but when someone leaves the hospital, why aren't they discharged with a prescription to carry them to?
Well, that has kind of changed a little bit over the years. They used to be discharged with a 14-day supply of medications. And John, remind me if I'm misstating my level of meds. But they used to be discharged with a 14-day supply of medication. Then it went to a one-week supply of medication and then a prescription. And depending on whether somebody had coverage to fill that prescription, they may or not get it filled, and so they'd be cycling back in after 14 days.
So they could be sent home with all the tools they need, but if you can't open it up, then, okay.
That's right.
All right, thank you. You want to go on to
Yes.
emergency psychiatric evaluation?
Right. I just wanted to provide a quick update in terms of the emergency psych evaluation EPE program closure and the transition planning we're currently doing with Henry Ford. It's currently scheduled to close effective September 6th, so not too far away at this point. From the MCCMH perspective, part of the reason why we looked at the discontinuation of this service was that services that are being provided at EPE are not a Medicaid-covered service under our contract in the emergency room setting. The MHPs receive dollars to provide that service within the emergency room. And so therefore, the MHP, the Medicaid Health Plan, is the payer for those services. And so we have been historically getting bills, and it's kind of a legacy practice. I think when the program was initially developed, the EPE would bill us for services that were being provided. But as we're looking at the population that's using that service, it's not necessarily the population that we're responsible for. They may be connected to the substance use system. They may be connected, may have payers that would be a Medicaid health plan. And so therefore, we felt like we were paying dollars out that weren't necessarily our responsibility. And we wanted to get a handle on that. And one of those things that we needed to do was to really look closely at the population that was receiving services there. A lot of times they would be coming in for med reviews because they've missed a med review at a service. And so they had their med review scheduled for Tuesday. They didn't make it Tuesday, so they go to EPE on Thursday. Well, we need to find a way to connect that consumer back to the service provider as opposed to providing an alternative service that's very expensive to get them their medications. So the direction that we've agreed with Henry Ford on is that if the consumer is currently in service with Macomb County Community Mental Health, that consumer needs to reconnect with their existing provider, get on their schedule for a med review. The docs, all the psychiatrists at the clinics should have the ability to provide an emergency med review as necessary if the consumer really needs the medication right now, or get back into service and receive those services from the currently assigned provider. If they're not currently in service with us and they are in need of behavioral health services, the connection needs to be made with the Access Center. Get a screening, let's assess their eligibility and need for services and get them into appropriate services, as opposed to have them going to a provider for a single service on a monthly basis. They're not engaging in treatment. They're not getting an ongoing treatment that's more likely to result in a better outcome and recovery. And then if the consumer's experiencing a crisis or an emergency situation, the place for them to go is the ER to receive services and get an evaluation. At that point, the ER contacts CMH for authorization for inpatient admission, and we approve as medically necessary. So that's where we're at right now with that. Any questions on that?
Thank you, Jim.
You're welcome.
Does that conclude your report? All right, that concludes the management reports, which leads us to item number 11. Any other agenda items? Yes, Joan.
I just wanted to say we had a good turnout at our Crossroads Golf. I think I came in the lowest. We have our director in the audience. Maybe he could come up and tell us a little bit about our golf outing. You want to come up to the podium? Is that okay with you, Madam Chair?
That would be fine. We'd like to hear the report and know who really had the lowest
How
score.
low my score was.
Thank you, Madam Chair. Yeah, we did have a very, very successful fundraiser on Friday. There was about 50 people that showed up. We were blessed with the fact that it did not rain during the putt-putt. It poured before it started. It quit during the event itself, and then it poured afterwards. So God was looking after us. So it was a great event, great event. I'm not sure of what the total of donations were at this point. We still have checks that are coming in, but right now we're sitting at right around $1,600 of donations for that event. So it was absolutely wonderful. Thank you to the advisory board for sponsoring that. It was truly a wonderful event.
Great, thank you.
And that money goes towards?
It goes towards our education program, social rec activities, and transitional employment support. So if somebody is seeking transitional employment, maybe they don't have the correct clothing to wear for that, then we could use that to help support purchase nice clothes to wear for work.
So thank all of you for helping out. Thank you, Bruce.
Thank you.
Anyone else? Okay, seeing none, we'll go on to item number 12, which is hearing of the public. Is there anyone from the public that would like to address this board?
Sorry, Madam Chair. Bruce Dutton, Director of Crossroads Clubhouse, 27041 Shaner. I wanted to come up to formally announce that on an annual basis, we have an open house. This particular year is a milestone for Crossroads Clubhouse. We will be open and operating for 25 years. There are only literally a couple other clubhouses in the state that have operated longer than Crossroads Clubhouse. So you as a board should be very, very proud of that accomplishment. That will be held on October the 3rd from 2 p.m. to 7 p.m. Crossroads Clubhouse is extending an invitation for the board to come and join us on that day. Dinner will be served at 5 o'clock. We want to pay special tribute to Mr. Kinch for his service to Macomb County Community Mental Health and in support of Crossroads Clubhouse. So he's been extended a special invitation. And I hear rumors that Mr. Kinch and I may have to wear a wetsuit that day because I'm hearing rumors that there may be a dunk tank on site. So please be prepared for that, as you know how rumors go. So we want to extend that offer to everybody. Hopefully you will find time in your calendar to come and enjoy the afternoon with us at Crossroads Clubhouse. Any comments, John?
You know, I accepted the invitation yesterday because I was out last week. I didn't hear any rumors about the wetsuit thing.
Yeah. I wanted to surprise you with that today.
And I think that's a
Thank you.
great fundraiser. You're charging per ball for the dunk, right? Be a long line. Anyone else from the public that would like to address this board? Anyone else? Seeing none, we'll go on to our last item, number 13, adjournment. This meeting is adjourned. Thank you, everyone.